Good morning, batch 23. Now we have the second part of the epidemiology and public health aspects of oral cancer, part 2. Okay, we go straight to the pictures. We have remembered these pictures that we see on the first part. Okay, this is all the type of cancer and pre-cancers. Alright. And now we go to preventions and control of oral cancer, whichever that we can do. Okay, this NSPCCP 2016-2020, the focus. Okay, National Surveillance Program and Cancer Control Program. So we see the focus will be on cancer control. How can we control the outbreak of cancer? It could be from research. I understand that doctors from PPUM also do research on cancer. Okay, health education and prevention, that is most important. Screening, the first part of screening, that will maybe we can detect the cancer early. Early detections, diagnosis, treatment, rehabilitation is it can still be treated and rehabilitate, and palliative care, okay, and traditional and complementary medicine. So far I've not heard of any traditional or complementary medicine that is what you call effective on cancer control. Okay, prevention. We have to see the primary preventions of cancer. The first part, when the patients are detected with especially pre-cancer lesions, the most important thing is counseling and health educations. Let it be individuals or community. Okay. Secondary preventions, you have to have the early detection and a prompt treatment. Screening program nowadays is like all the health programs by the health facilities. They will do the screening for cancer. Let it be cancer in other parts of the body or oral cancer. So this is where our part is. Opportunistic subject being offered oral soft tissue examination when they go to clinics may be the most effective strategy. If we caught patient with what we suspect are pre-cancer lesions or early cancer detection, that is the point where we have to follow up the patient and to refer the patient to the oral surgeon. Okay, strategies for application in practice: early detections, as we said just now, and diagnosis to ensure better survival rate. Less than 40% of cases are diagnosed at early stage, and 5-year survival rates for oral cancers. If you detect early stage, T is 0, the 5-year survival rates around 83.7%. If it's regional, 5-year survival rates for oral cancers are about 47.6%. And if it's distance, there is a metastasis to the cancer, but the survival rates will be less. That is around 25.6%. Yeah. Okay, strategies for application in practice. Okay, immunocompromised patients, frequent checkups and treat dental caries, control of xerostomia, candidiasis, and mucositis. What do you mean by immunocompromised patients? patients with other health problems, example old age, or age over 60 years and then medically compromised patients, like she have experienced cancer in other parts of the body before, or patients with diabetes, hypertension, heart problems. They are more prone also to have cancer. Okay. Patients on radiotherapy. Patient on radiotherapy, before they do the radiotherapy, they were asked to remove sources of infection intraorally. Alright, so that if we remove the problem teeth earlier, so when they undergo radiotherapy, that tooth will not give them extra problems. Prevention, tertiary prevention, disability, limitation and rehabilitations, prosthesis for patients with loss of jaws, monitoring for recurrences. Examples, when they have cancer of the maxillary or one side of the maxilla, then they got to remove the maxilla. Then in order for patient to be able to eat or to be able to survive, they will have to replace the maxilla. Alright, the whole maxilla has got to be replaced so that patient will look better, and it may have a function, the maxilla and the mandible may have a functioning, maybe functioning again, maybe not fully, but it's much better than not having the maxilla. Yeah. And monitoring for recurrences with the prosthesis in place. Of course, there is more reason for us to check and recheck the patient every now and then, or at certain sequences, so that there is no recurrence of cancer. Prevention and control of oral cancer. There are a few ways to control, to prevent and control of oral cancer. Mainly focus on modifying habits associated with the use of tobacco. 3 well-known approaches. Okay. Regulatory approach. Second one, service approach. And third one is educational approach. Okay, why is it associated with the use of tobacco? Because previously we have seen with the use of different ways of using of tobacco will end up the patient having cancer, oral cancer. Okay, and the first part is the tobacco cessations. Stages of development of addictions. The initiation and development of tobacco use among children and adolescents progresses in stages. 1. Forming attitudes and beliefs about tobacco, trying tobacco, experimenting with tobacco, regularly using tobacco. The 5th one, becoming addicted to tobacco, and this process generally takes about 3 years. Okay, but if they are trying out on cigarette smoking, the effect or the process will be much faster. Even after taking the first puff of the cigarette, they were already addicted to the tobacco or to the cigarettes content of the tobacco. Okay, so it is very easy for children and adolescents to get hold of a cigarettes, even though we have laws to say that children below 18 years cannot buy cigarette from the shops. Guide to counseling for tobacco cessations. Okay, there are 5 A's and there are 5 R's. What is the 5A? 5A is ask, advise, assess, assist and arrange. What is ask? Ask patients about their use of tobacco at every visit. Check for oral signs of tobacco use, which are stained teeth, halitosis, periodontal disease, tooth mobility. Right? You have to assess the addictedness of patient to the tobacco. Okay, advice. Advise non-users to never use tobacco. Encourage never users to stay away from tobacco. Affirm and congratulate those who have quit tobacco. Advice for quitting should be clear, strong and personalized. Right? Assess. Ask every tobacco user if he or she is willing to quit at this time. Assess the risk of relapse. An individual who has quit before, even for just 30 days, has a lower risk of relapse. Assist. Assist with quitting. If the patient is interested or show an interest in quitting the tobacco, so for whatever reasons, we will try to assist them to quit smoking. Okay, assist with quitting. Set a firm quit date, ideally within 2 weeks. Set support from family, friends, co-workers. Review past quit attempts. What helped or led to relapse. Okay, in this case, you really have to assess the patient properly and also to have ideas what has led the patient again to relapse. Okay, so that you can do the proper things to help them quit. In not every health center, most of the health center under the MOH already have program for quit smoking. So you have to refer the patient to them so that they can do the necessary thing to help patient quitting smoking. Right? And at the same time, you have to get the support of the family, or the person have to get support from their family, the friends and co-workers, those people that are what you call close to him. Right? And you have to review how many times they have attempted to quit smoking, what causes them to relapse, so that you can tackle the problem better. Preventive dentistry. Tobacco cessation counseling, 6 monthly or yearly checkups to catch dental and oral problems yearly, detect possible oral cancer early. Pharmacotherapy. This pharmacotherapy is developed for people attempting to stop tobacco use, lessening the intensity or the withdrawal symptoms. This pharmacotherapy also there are two main types: nicotine replacement therapies and antidepressants. As we all know, patients, let it be young or old, if they decided to quit smoking, there may be some antidepressant, depressed. The patient may be depressed, or they do not know how to behave themselves, how to take care of themselves. So families and friends are needed to help him to cope with the withdrawal symptoms. What could be the withdrawal symptoms? Angry, depressed, want to eat a lot, or no, not the normal diet, and there are many more that they need their friends or their families to help them in this matter. Nicotine replacement therapy helps in lessening craving and other withdrawal symptoms. Nicotine replacement therapy available are nicotine gum, nicotine patch, nicotine inhaler, nicotine nasal spray, or nicotine lozenges. It is, however, contraindicated to be used in pregnant women or lactating women, cardiovascular disease patients, endocrine disorders patients, inflammation of the mouth and throat, esophagitis, gastric ulcers, and diabetes. Patient needs the greatest support during the first 3 weeks after stopping. Attacks usually do not last for more than 3 minutes. Alternatives such as chewing aniseeds, taking walks, deep breathings, exercising, it may help them to overcome the craving for tobacco. Withdrawal symptoms include craving, depression, insomnia, irritability, frustration, anxiety, unable to concentrate, restlessness, decreased hair, increased appetite, and weight gain. Antidepressant. First line therapies, bupropion SR and selegiline. Second line therapies are clonidine and nortriptyline. Combined with nicotine replacement therapies. When they cannot cope already with the sign and symptom for nicotine replacement therapies, they can be helped by giving an antidepressants. With the combination of the two, it may help them to overcome the first few days of after the quitting smokings. Relevant for quitting, based on personal reason, feed patient with information, risk of continuing tobacco use. Okay. Acute risk, long-term risk, and environmental risk. Relevant of quitting based on personal reasons. What's the patient's reason? Is it you want to get married, or you want to start a new career in life, or is it he had done with smoking, he don't want the smoking anymore? Right? If a patient can say that, that is a good sign, but it's a very strong-hearted patient. Risk of continuing tobacco use. Okay, acute risk. What's the risk of continuing tobacco use? Acute risk, immediate risk. They be coughing. They be coughing for some times, and may later develop CA of the lung. Alright, and long-term risk. What could be the long-term risk? I understood also that people who smokes early in age, they become important. Long-term risk, environmental risk. Of course, they cannot nowadays smoke anywhere that they want. They have these places where like restaurant, shopping mall. Actually, they cannot smoke in there. Okay, there is a regulation that there should not be smoking in the shopping complex. Rewards of quitting. After you consult them, you talk to them, you tell them consequences, the bad parts of quitting. Now we want to reward for those who are quitting. Okay, improve oral health, increase energy, food tastes better, money is saved, set a good example, the longer and healthier life. Once you quit smoking, this is what you can get, all the privileges in life that you will get. Okay. The fourth one, roadblocks to quitting. Fear of withdrawal symptoms, failure, weight gain. That is very true also. Especially women, they keep on smoking, thinking that they'll be slim forever. If they are not smoking, then they will become a bigger size. Well, that's not totally true, huh? Fear of withdrawal symptoms, failure, weight gain, lack of support. Of course, if you don't get the support of your family or your immediate family, it will be difficult on you. Okay? And the enjoyment of tobacco. How do you enjoy tobacco when you see there's a lot of ingredients in tobacco is carcinogenics? Alright, and the fifth one is repetition to motivate the patients. Maybe after a month or so, they cannot stand the craving for tobacco, and there they go, they start smoking again. Alright, so you have to be to motivate the patient, you have to be in their shoes to understand them and to advise them. Alright. There's one signboard that we found somewhere. Please don't throw your cigarette ends on the floor. The cockroaches are getting cancer. That's how effective cigarette is on cancer, whatever cancer it is. Okay. For public health strategies of MOH, we have prevention and control of oral cancer. we have tobacco control in Malaysia. Okay, in 1983, as early as 1983, the Ministry of Health Malaysia, in collaboration with the Malaysian Medical Association, carried out the country's first major anti-tobacco effort. The workshop on smoking and health was followed by the launch of the nationwide No Smoking Day campaign. The first national level World No Tobacco Day in Malaysia was celebrated in 1993 when the Prime Minister's wife launched the theme, Health Service, Our Window to a Tobacco-Free World. Okay, current initiatives in tobacco control. Okay, A. Legislation, B. Enforcement activities, C. Anti-tobacco promotion, D. Smoking cessation services, and E. Tobacco taxations. Okay. 1973, smoking is banned in cinemas. Alright. In 1975, Ministry of Health and Ministry of Defense banned smoking in all their hospitals, clinics, and health centers. Okay. In 1977, health warning, merokok diharamkan jika merokok membahayakan kesihatan. On cigarette packs, an advertisement is made. Mandatory magazines are exempted from this requirement. Okay, in 1980, World Health Team, Smoking or Health. 1981, smoking ban and on aircon train coaches and in buses. Okay, 1982, cigarette advertisements banned on radio and televisions and in government publications. 1986, No Smoking Day campaign. 1987, No Smoking Week campaign. 1988, 5% increase in tobacco tax. 1992, 100% increase in tobacco tax. 1993, Gazettement of Control of Tobacco Products Regulations. 1993. In 1993, Gazettement of Control of Tobacco Products Regulation, 1993. 1994, tobacco legislation comes into force. 1995, National Fatwa Council rules smoking to be haram, that is prohibited or illegal in Islam. 1996, smoking is banned on all domestic flights. And in 2000, smoking is banned on all international flights. Okay, our achievements: to educate high-risk communities on the risk factors for oral cancer, oral health promotion activities and dental health education talks for oral pre-cancer or cancer program 2002-2008. In 2003, number of estate or kampung visited 114. Repeat is 21. And number of patient screen, oh, that's a lot, 3,628. And number of health promotion activities held is 91. And numbers of dental health talk, number of talks given is 54 for the whole year, and it's only about number of talks given is about 54, and number of participants about 2,088. Okay, so the number of participants has increased ever since every year. Then we have with other activities. Training dentists' role in smoking cessations, 2005, and ongoing training targeting all MOH dentists. Okay, we have a program on dentist role in tobacco cessations. Okay. In 2006, booklet on oral cancer, the visible upper aerodigestive tract cancer, a referral guides in primary healthcare professionals. Okay, and same year you have this Initiate Mouth Cancer Awareness Week. This is important. And third one, okay, the third one, pamphlets on mouth self-examinations. Okay, Initiative Mouth Cancer Awareness Week, and we have come up with pamphlets of mouth self-examination. Okay, in 2007 we have this Tak Nak, Jom Tak Nak Merokok campaign launched by the Prime Minister at that point of time, which they feel that it is not very effective. Alright, mouth self-examination, of course, they want the book, or they want us to do the self-examination for them. Okay, and then they also have come up with pamphlets on mouth self-examination in Malay, Chinese, and Tamil. Okay, everybody understand their own languages. Okay. After that, now we have the steps of oral cancer screening. This is what we call self-examination, safe oral mouth examinations. We have to look into the upper lips, lift up the lips. We have to do it for the lower lips. Okay, and then we have to do it for the palates. Okay, if none of that have any cancer, if you feel that you need to go and see a doctor, come and see a doctor. Okay. So with self-examination, we will look into the whole of our oral cavity, from the lower lips, the upper lips, alright, and the palate. Okay, and then we have on the lingual region, and then at the same time we put mouth there. Okay, so after upper molar, then we come to the anterior mandibular region to look for the oral cancer or any other abnormalities. Alright. Okay, Mouth Cancer Awareness Week. We have this second week of November, yearly since 2006. Okay, we have free screening, campaign, health education, promotion, mouth cancer awareness walk. Issues and challenges. What are the issues and challenges? Low uptake in the screening program, low compliance of referrals, late diagnosis and treatment, patient fail to come for screening, diagnostic or logistic, patient services, later referrals, services, late referrals, long appointment for investigation or treatment locations. Most cases were detected at late stage. More than 60% cases seen by surgeon are pre-malignant or malignant lesions. Okay, 20.7% detected at stage 1, while in fact 60% of patients detected with cancer at stage 3 and 4. Okay. Effectiveness of health education and promotion activities related to oral cancer and these habits. Public awareness on oral cancer. Public awareness on oral cancer or NOSHA 2010 will allow them to have a public awareness on oral cancer. National Oral Health Plan for Malaysia 2011 to 2020 concerning tobacco use and oral cancer. Tobacco use is a risk factor for development of periodontal disease and oral cancer. Smoking prevalence is high in Malaysian population, which is 21.5%. with 46.4% of males being smokers. Okay. Around 9%, about 8.7% of adolescents 13 to 18 years of age are already smokers. Okay. So now we have tobacco use and other risk habits like betel quid chewing and excessive alcohol consumption. They are prevalent in certain communities. It has to stop. Okay, again, late detection of oral cancers contribute to high disease burden, morbidity, and mortality in affected individuals, and is also an area of concern. Only 26% were detected at stage 1, while the MOH reported a lower figure of 23%. Okay, again, recommendation from the National Oral Health Plan for Malaysia 2011-2020. To combat the predicted sharp increase in new cancer cases, it is essential to embark on planning and implementation of effective cancer control strategies, such as reducing tobacco use and alcohol consumption, promoting healthy lifestyle and diet, performing early detection through screening and mouth self-examination, or as well as pushing for greater awareness on risk habits for oral malignancies. Okay, role of cancer registries. I would like you all to look into the role of cancer registry or to understand how they register patient with oral cancer. Okay, they use a different term for oral cancer. So I want you all to understand that. To reduce the incidence, morbidity and mortality of cancer, to improve role of cancer registries, to improve the quality of life of cancer patients through the systematic implementation of evidence-based interventions in prevention, early diagnosis, treatment, and palliative care. So that's what I've got to say for prevention of oral cancer. And again, I will advise you all to look into the role of registry or cancer registries in Malaysia. And I want you all to understand how they divide the sections section of the mouth into a different cancers. Alright. And what is this date? What is this actually? This is a May 31st, where the world announced it as World No Tobacco Day. So every day, everybody do not take any form of tobacco for that day. Alright. So with that, I thank you all. Remember, tobacco is bad for you. Quit smoking and save your life. Okay, thank you everybody. See you again next week.